Assalamu alaikum. Honoring prevalence of thalassemia and sickle cell disease. This is our lecture today. My name is Dr. Zeeshan Abedin, and we will continue with our lecture. This is a very important module as well. Although this lecture is very simple and easy, we have to guys don't have to panic about it. So we have to have certain criteria for learning objectives. Of course, as we know, we should know about the definition of thalassemia and sickle cell disease. What are they? We also know different types of thalassemia and different types of sickle cell disease. We should be able to also know about the prevalence of thalassemia and sickle cell disease. But usually in exams, we will be quizzed about thalassemia and sickle cell disease. What are they and how to be differentiated? You know, to also know about the pictorial and also sign and symptoms that they have to do and the management and the different types of thalassemia and how they present in the clinical scenarios and in the community. As you know, thalassemia is an inherited form passed from parents to their children through genes or blood disorder. It has impairment of hemoglobin production in which there is partial or complete failure to synthesize specific types of globin chain. There are two types, alpha and beta. In alpha thalassemia, the alpha genes are deleted, loss of one gene or loss of both. For each chromosome, 16 may occur in association with production of some or more alpha globin chain. Got it? We have to know the types, alpha and beta, and which is more lethal and which is more prevalent in the community. To the next slide. In beta thalassemia, we have defective beta thalassemia usually results from a salient point mutation causing no beta or reduced beta chain. So that's definition as you can see it's simple. Beta thalassemia, so they will have a normal chain, there will be mutation and there will be no production of beta or reduced beta chain production. All right. So this alpha and beta thalassemia is self-explanatory as well. So it is treatable disorder that can be well managed through blood transfusion inhalation. And beta thalassemia is more prevalent in the community as compared to alpha thalassemia. Here we have a pictorial in which on the left hand side you can see we have normal blood cells, RBCs. You should know about their structure and also this thalassemia. This is a very important picture and every student should know about this picture. As we know, we have simple inherited disorder. We should know how the trait is passed, normal blood and thalassemia trait. As we can see on the left-hand side, we have normal parent and we have a carrier mother. What we can see is normal, 50% are normal and 50% are trait as compared to the other in which both the parents, mother and father, are carriers with thalassemia minor. So what happened in the thalassemia minor, the offsprings will be 50% will be carrier, healthy carriers. With healthy carrier means they will have no symptoms and they have a normal lifespan. The other person, 25% would be normal and 25% would be thalassemia major and would be affected and will show all the signs and symptoms that thalassemia would have. So they will be sick child. Prevalence of thalassemia in Pakistan and thalassemia, we know that we have a lot of thalassemia. You must have gone through the media that we have regular educational material, thalassemia, and especially in Ramadan, we have seen a lot of blood donations that happens, which have the blood cancer hospitals to collect the donations. As thalassemia carriers, 5% of the population, total carriers are 8 million. Thalassemia births per year is 5,000 to 6,000, and thalassemia major prevalence is 60,000. Prevalence of thalassemia in Pakistan with the thalassemia rate ranges between 5 to 7%. Thus, there are more than 10 million carriers in the country, and every year around 5,000 children are diagnosed with carrying the thalassemia in Pakistan. Thalassemia is an inherited disease of autosomal hemoglobin. As we know, it's an inherited disease. Its name derived from Greek word thalassa and sea, and the condition was first described in population living near the Mediterranean Sea. Usually, they are found in Africa, Middle East, and Asia. On the next slide, we can see the next thing we have the clinical scenarios. How will we differentiate between how will we diagnose thalassemia? There are various signs and symptoms of thalassemia. As we know, we can see thalassemia will have deficiency of hemoglobin. Of course, if there will be deficiency of hemoglobin, there will be anemia. First thing you will see automatically the symptoms will recur because of the decreased hemoglobin, decrease of oxygenated blood. Patient will have fatigue and weakness. Correct? As it's shown in the top left corner. Then we have pale or yellow skin. It is also because of the breaking down of the RBCs. As we know, it's broken down into heme and globin, and then there's release of bilirubin, bilirubin, and all together consideration that leads to have a genuine yellow pale skin. Facial deformity, especially the frontal bossing of the forehead, there will be, but primary is fatigue, weakness, their failure is skin, dark urine, there would be there will, of course, there would be lots of deficiency, weakness, there would be slow growth as well. So there will be stunted growth. Yeah. The children would be not as tall as they should be. Then would be abdominal swelling. Diagnosing thalassemia, how diagnosis need to start with the patient's individual history and family history and ethnic background. You have to have a detailed history, then you have to perform physical examination. And apart from that, we have to do physical examination. What will you do? We have discussed in the previous slide. You will see the anemia, you'll see the pallor. We have how will you see the pallor? In the conjunctiva, in the hand, in the skin, then the jaundice indicating hemolysis, splenomegaly due to cooling of abnormal cells, cell performance, especially in beta thalassemia. So lab investigation, what will we do? The most reliable method for diagnosis is hemoglobin analysis. High performance liquid chromatography, electrophoresis. If the electrophoresis is the next thing after you see the primary blood reports, you will go for the electrophoresis in which you will have some knowledge about it. Okay, this is thalassemia. Then chromatography are available. And genetic testing can be done as well. Molecular diagnosis and are needed in case of severe transfusion dependent, mild, moderate, and non-transfusion dependent cases. Diagnostic evaluation HB level decreased, less than 7, increased number of RBCs, mean corpuscular hemoglobin concentration low, peripheral blood smear, many polypocytes, indicated RBCs, reticulocytes counts low, usually less than 10%, hemoglobin electrophoresis, elevated level of HbF and HbA limited amount. Prevention of thalassemia. Although thalassemia cannot be prevented, only the following measures can reduce the risk of having a newborn. Parents, the genetic test for the presence of thalassemia, gene, prenatal screening, provisions of public awareness and education about thalassemia. Here's the next slide about sickle cell anemia. The sickle cell anemia is one of the sickle cell disease that are hereditary illness. This also is heavy disease, and it can be detected in the newborn. It has an impact on the structure of red blood cells, which transport oxygen of the body. Normal RBCs are typically spherical and flexible, allowing them to pass through blood vessels with ease. Some RBC cells in the sickle cell anemia are shaped like sickles or crescent. What happens if there are sickle cell or crescent moons? This is the very important thing. Then it's usually asked again and again, and all of the signs and symptoms will be because of this sickle cells or crescent moons. If you will know the pathophysiology and the concept of it, you will never go wrong. Because of the sickle cell crescent, it becomes hardy and sticky, slowing or blocking blood flow. Treatment can help reduce pain and avoid disease-related consequences. So what happened? It becomes hard and sticky, slowing and blocking blood flow, in which there would be infarction, organ damage. Of course, the vessels are blocked, and because the vessels are blocked because of the sickles or crescent moons, there that's what the symptoms will they have? They will have acute pain. That's the basically main symptom of sickle cell anemia, that they will have acute pain if they have to go to the ER. All right. Okay, let's go to the next slide. Sickle cell disease is a genetic disorder caused by mutations in the beta globin genes that leads to faulty hemoglobin protein called hemoglobin S. So that's easy. Sickle cell disease, and you can always memorize with hemoglobin S. Hemoglobin S changes flexible red blood cells into rigid sickle cell shapes. So sickle cell shape, so we will see in the figure ahead, and it will be self-explanatory, and I will explain it to you as well. These sickle cells can block blood flow and results in pain and organ damage. This is very important, and you guys should know about. These are the consequences of the sickle shape. Otherwise, everything would be okay if they would be spherical, and the blood will run smoothly across the blood vessels. So this is one of the vessels pictorial, that what I was telling you. And on the left hand side, there is normal RBCs. You can see it has a typical round spherical shape. Normal erythrocyte RBCs, they're oxygenated and everything. Because of this formation of hemoglobin S, they would get brittle and they have become gelatinous, and because of the gelatinous, they will form a sickle shape. They become shaped like sickle, and because of this sickle, this gelatinous, then in the long term, they will become permanently sickle shaped, and it will what it will cause in the right hand side, what you can see the sickle cell anemia, in which you can see the same kind of vessels in which right and left it's divided into it. But what happened? This sickle cell, in which you can see the rounded portion, all the sickle shapes are collecting in one place. And what's happening? It's becoming a more like a thrombus. It's blocking the vessel. It's causing vaso-occlusion. Vaso-occlusion. What will happen? The sickle red blood cell will cause uh, vaso-occlusion because of their shape, sickle shape, because they become rigid. They'll, it will be more viscous, and they will be easily aggregated. They can block the small as well as blood vessels. And it will cause what symptoms they will cause? It will cause symptoms of acute pain. They will cause organ damage. All right. Sickle cell disease. Sickle cell disease results from a single glutamic acid 2 value substitution at position 6 of the beta globin polypeptide chain. It is inherited as an autosomal recessive trait. Homozygotes only produce abnormal beta chains that produces hemoglobin S, and this results in a syndrome called sickle cell disease. Heterozygous produces a mixture of normal and abnormal beta chains that make normal HbA and HbS, and this results in clinically asymptomatic sickle cell trait. Let's move on to the next slide. Epidemiology of sickle cell disease. The greatest prevalence of hemoglobinopathies occurs in tropical Africa, where the heterozygous frequency is over 20%. In Black America, sickle cell trait frequency is 8%. Individuals with sickle cell trait is usually resistant to the lethal effects of falciparum malaria in early childhood. So really what happens, it's more prevalent in Africa. So it's in Africa, the tropical Africa is more prevalent. So it's mostly found in Black America. It is not that common in Asia and Southeast Asia as compared to thalassemia. Thalassemia is like bigger thalassemia is more prevalent. Symptoms of sickle cell disease, anemia, because sickle cells are short-lived or destroyed, there are less red blood cells available in the body. Pain crisis or sickle crisis, acute chest syndrome, splenic sequestration, including stroke, jaundice or yelling of the skin, eyes and mouth, priapism. So what happened? There will be anemia, of course, sickle cell, we have done it. We have already told you in the previous slide, there will be pain crisis. I've told you why the pain crisis will happen. And or it's also called sickle crisis. This is the primary and acute symptoms, and it is basically the telltale sign of sickle cell. Acute chest syndrome, why will happen? Because of the same of clogging of the sickle shaped cells in the vessels, splenic sequestration, stroke will happen. Wherever they will go, the sickle cells, they will cause blockade. So it can happen anywhere, in any vessel, and they will have the symptoms as it is. Of course, it will go in the brain, it will go into the brain vessels, it will cause stroke, it will go in the heart, it will cause acute chest syndrome. It will go somewhere else, it will in priapism, it will cause the same. It will cause what is priapism? It's painful erection. This is one of the diagram as you can see. We have CDA, we have seen on the left hand side of the sickle cell, then we have again shown the sickle cell vessels has been blocked. It will cause hemolysis, anemia, and then there will be different because of the vessel blocking, there will be severe stroke, paralysis, and death. Then it will cause retinopathy, blindness, and hemorrhage, avascular necrosis, hematomegaly, gallstones, splenomegaly, splenic sequestration, autosplenomegaly, hematuria, hypospleninuria, avascular necrosis, abdominal pain, dactylitis, hand-foot syndrome. That's the most common cause. Priapism, pain, osteomyelitis, and chronic ulcers will be the symptoms. Types of sickle cell disease, as we can see, what are the types of sickle cell? Hemoglobin SS, sickle cell anemia, hemoglobin SC, sickle cell disease. So most common type of sickle cell disease is SCD, sickle cell disease, inherited one sickle gene from whose parents, regarding as a severe form of SCD. Sickle cell disease inherit one sickle cell gene from one parent and one C gene from the other parent. Similar symptoms to type SS less anemia. Hemoglobin SP, sickle cell beta thalassemia, with cross crescent shaped RBCs that break down while thalassemia produces small RBCs. Sickle cell beta zero thalassemia, there are two types of beta thalassemia. Sickle beta plus thal is mild, while sickle beta zero thal is severe form of SCD. Hemoglobin ST, SCSO inherit one sickle cell gene and another abnormal hemoglobin gene. This is the laboratories that we will have. We will have WBC count increased, RBC count will be decreased, hemoglobin will be decreased, hematocrit reading will be decreased, reticulocyte will be increased, it will electrophoresis when we will do, it will be positive, it will be albumin cast, serum bilirubin will be increased, of course, that's why we have yellow discoloration. We have platelet count, which is increased, and bone marrow examination will have increased red cells. We'll go on to the next slide in which we have shown this world map in which what you can see is 1 to 4.9 is which is shown in maroon in red is around live birds for 1,000 live birds. It's happening because mostly in Africa. As you can see in the brown, it is 0.0 to 0.99%. So and as well, Pakistan comes in the brown category, and as well as the America, North America is also comes, and most of part of the South America is also there. So mostly the African region are mostly affected, and from 1.4.9 per 1,000 live birth to 9.99, 9.9 to 18.9, which is usually covered in blue and purple in color. So as you can see, they are only affected the whole of Africa. Prevalence of hemoglobinopathies in Pakistan. What we have a pie chart over here that describes the thalassemia major, which is shown in dotted red in color, which is 21%, as well as thalassemia minor, which is 13%, and sickle cell disease, which is shown in 5%. And iron deficiency anemia is 60%, which is the major chunk of it in pie chart in whole of Pakistan. And that is all, and that's the end of the lecture. Thank you.